Hello, I'm Gina Moringa-Rambe, and I'm the managing editor of Harvard Public Health and today's moderator. This is the last installment of this series of Public Health in Action focused on mental health innovations. And today we're looking at family-based crisis intervention, or FBCI. FBCI was first developed for use in emergency departments, where it helps stabilize suicidal adolescents and offer tools to them and their families to safely manage crises at home. The approach helps avoid the phenomenon of boarding, which is when teens stay without treatment, sometimes even for days, in hospitals while they wait for beds to open up in inpatient psychiatric facilities. Another thing FBCI does is help adolescents and their families communicate better about the feelings and the situations that lead to suicidal ideation or suicide attempts. And now the approach is being adapted for primary care settings. So today we'll hear from the researchers who've developed, administered, and measured the impact of FBCI. Joining me today are Dr. Abigail Ross, who is Associate Professor at the School of Social Policy and Practice and at the Perelman School of Medicine at the University of Pennsylvania, and a research social worker at Boston Children's Hospital. We also have Dr. Elizabeth Worf, a research social worker and the former director of the emergency psychiatry at Boston Children's Hospital, where she developed FBCI, and also an assistant professor in psychiatry at Harvard Medical School. And we have Dr. Sharon Herbert, Director of Belonging, Diversity, Equity, and Inclusion, and the former supervisor of the Mental Health Emergency Services team in the emergency department at the Children's Hospital of Orange County, where she's implemented FBCI. So to begin with, maybe each of you could describe in a nutshell what family-based crisis intervention is. Dr. Worf, let's start with you.
Sure, yes, and thank you for having us here. We're all very happy to talk about the family-based crisis intervention. FBCI, as I'll call it, is a single session intervention developed for work in the emergency department with suicidal adolescents and their families. And it is designed to provide treatment at the time of crisis in lieu of psychiatric hospitalization, which is what usually happens with suicidal teenagers who come to the ED. The goals of FBCI are to stabilize the suicidality in the adolescent, to provide tools to help both the adolescent and the family members cope when they return home in case of any future crises, and to facilitate communication between the teenager and the family members. So that's it in a nutshell.
That's great. Maybe Dr. Herbert, you could add something from your perspective.
Thank you so much. In addition, one of the things that we focus on is that safety and coping planning. So that stabilization is truly key, and finding ways to help the families understand the ways that they can empower themselves so that they can take care of their child and the child can have those skills is essential.
Great. And Dr. Ross?
Thank you so much for having us. We're really all delighted to be here. I think Drs. Worf and Herbert really captured FBCI well. There are several, it's a modular intervention. So there are 4 modules: psychoeducation, cognitive behavioral skill building, therapeutic readiness, and safety planning, as Dr. Herbert mentioned. And all of this is constructed within the context of developing a joint crisis narrative, which I really think is the crux of FBCI. I think we'll talk about that a little bit more later.
Great. Thank you so much. Dr. Worf, you developed FBCI in response to the boarding crisis that you were seeing every day, really, as Director of Emergency Psychiatry at Boston Children's Hospital. Can you describe that crisis for us a little bit?
Sure. And I bet a lot of people in your audience have heard about psychiatric boarding because there's been a lot in the press about it. Boarding is when a patient comes into the emergency department, a psychiatry patient, a mental health patient, and they're assessed to need inpatient level of care. So that psychiatric hospitalization I was talking about previously, but for whom there are no available beds. So there's nowhere for the patient to go and be hospitalized. So what happens is they sit in the emergency department and they just wait. And that's why they're called boarders. They are boarding. And sometimes it's hours, sometimes it's days, sometimes it's weeks. And when I came to run the emergency psych service at Boston Children's Hospital, I noticed that there were increasing numbers of psychiatric boarders among the patients there. But I didn't know who the boarders were. So I did a study to look at what helps us predict who are going to be the patients to board. And the study showed that it was primarily suicidal adolescents who were the patients who were the most likely to board. We've all heard about the increase in suicide over time. And I think the pandemic really increased the numbers of kids who have had suicidal episodes. So the boarders were a big problem in our emergency department at that time. So I thought there has to be a better way to deal with this crisis than having them sit. And I noticed that in emergency medicine, they had a different way of doing things. So if a kid came in with a bad asthma attack, they would treat the patient and try to reassess at intervals and see whether they could try to discharge the patient home. So that's really what gave me the idea to try to develop treatment for these suicidal kids instead of just having them board. In emergency psychiatry, the way of managing patients forever has been assessment and disposition with little or no treatment. And so that was the unique thing about this intervention, was introducing actual crisis intervention treatment for these patients. And that's how the intervention got developed.
And Dr. Herbert, you've used this intervention, you've used FBCI, and you've trained others to use it too. Can you talk us through what happens when a young person comes into the emergency department?
Yeah, absolutely. I'd love to share. So typically in our emergency department at Children's Hospital of Orange County, the kids who receive FBCI are kids who've come in for suicidality. However, we do also have youth who present for a medical concern and they screen positive on something called the Ask Suicide Screening Questions, or the ASQ, which is administered by our triage nurses for all kids who are 11 and above. So we would also use FBCI at times for them. And in essence, we're just like we've kind of initially started talking about, we're diligently working to establish that joint crisis narrative while providing and helping shore up any coping strategies that they have to manage their symptoms. So what happens? Well, initially when they come in, we're going to inform them about the expectations of our time together. Then we're going to talk about the ways in which we're going to meet with the patient or the youth. Then we'll meet with the caregiver or caregivers. And then lastly, we come together because we want to hear those narratives from both of them. And then we also want them to hear each other's perspective. So many things happen during that time when we're working with the kid. When it comes to thinking about why they presented that day, we're going to be asking about, we want to understand what happened, what led to them coming this day, that particular day, and also a little historical context related to their presenting issues, so depression or suicidality. As that conversation is taking place, there's so much that we can do. So they're talking about their symptoms, maybe depression, suicidality, maybe even some anxiety, and we get to hear from them, the people who have the lived experience, these youth, about what they understand of why they're experiencing what they're experiencing. And we can fill any gaps by providing psychoeducation around depression and suicidality. Additionally, we have the opportunity to hear more about the skills that they utilize to help them manage their symptoms. So many times they have various coping strategies that they're using, and we can practice those in the moment and then also provide them some cognitive behavioral skills in the moment. So that could be relaxation skills, like identifying cognitive distortions, behavioral activation, problem solving, so many pieces. And while that conversation continues on, we start thinking about how do we help them with a safety and coping plan. They're talking about triggers, things that lead to them feeling worse and worsening their symptoms. We talk about those things, or identify people they feel like they can contact. So this conversation with the caregivers is quite similar, but they have a different perspective because they're not the individuals who are living this experience. So we continue to use that modular approach that Dr. Ross had mentioned, in addition to maybe sharing some additional information that we've learned from their youth. The last piece is bringing everybody together. We want to bring those stories and and perspectives together. We love to see the adolescent share their perspective as well as the caregiver, so that they have practice sharing their symptoms and sharing what their experience is. That gives them practice for when they go home, if that is that's the final decision for like the next step. So the last piece is developing that really robust, well thought out safety and coping plan, which looks at readiness for treatment, as well as how to keep them safe, what their triggers are, what the coping strategies are, the identified individuals, crisis numbers, and lastly for us, what we do is make sure they have an appointment set up before they leave, or we call them the next day to ensure that they have an appointment with an identified mental health practitioner.
That's fantastic. Thank you. Thank you for that rundown. Dr. Ross, you helped develop FBCI. Can you share from the evidence base that we have that shows FBCI works and tell us whether it works for everyone?
Oh, what excellent questions. Sure, I'd be happy to talk a little bit about that. And actually, it was Dr. Worf who really started the research on FBCI, I think, at the beginning of the 2000s, where it was originally developed. And he and her colleagues conducted an open trial of FBCI. And what that means is that everybody who's eligible, and Dr. Worf, correct me if I'm mistaken on this open trial eligibility, I believe it patients ages 13 to 18 and their families presenting with suicidality within the past 72 hours. So everybody presenting to Boston Children's within, I think it was an 18-month time period, who met those criteria at minimum, was able to receive FBCI. And the results there were encouraging, and that prompted us to actually conduct a randomized clinical trial of FBCI. And that's when I was able to come on board the FBCI train and join in the fun. And a randomized clinical trial, this is not where everybody who is eligible automatically gets it. This is people are randomized either to get FBCI or to get treatment as usual, which, as Dr. Worf referred to earlier, is really no treatment within the emergency department. And that was about a decade later, I want to say. And that's the randomized clinical trial is really the gold standard of experimental and intervention research. And from that trial, we had a little under 150 adolescents. I want to say it was 142, along with their families. Some very encouraging results. So FBCI patients and families who received FBCI were significantly more likely to be able to be discharged home with additional supports relative to those randomized to the treatment as usual condition. And I believe it was about 62% of patients receiving FBCI were able to go home compared to 32%. So a little under 1/3 of patients who got treatment as usual. As a result of that, significantly fewer patients and families who received FBCI also boarded. So they didn't have to wait for treatment. And that's kind of an artifact of the phenomenon of boarding, where people are waiting for that inpatient bed. So if you don't need the bed, you don't need to wait, right? And I think only 22% of patients who received FBCI boarded relative to about double that, 43% of patients who received treatment as usual. My favorite outcome, nobody in either arm of treatment died by suicide who we were able to reach over the follow-up period. And encouragingly, and I think this really speaks to one of the strengths of FBCI, families reported being more empowered and relative to their counterparts in the treatment as usual condition. And they also were more satisfied with care, according to the client satisfaction questionnaire, the CSQ-8, relative to counterparts in treatment as usual. So that was the RCT, and then that inspired a transportability trial, which means that we wanted to test, can FBCI be used in emergency departments outside of Boston Children's? And spoiler, we know that it can, because Dr. Herbert already implemented very successfully at Children's Hospital of Orange County and with new staff at Boston Children's. So we tested this with Children's Hospital of Orange County, UNC, and also Boston Children's under new leadership. Also very encouraging results. And I can talk about that a bit later when we talk implementation.
Great. Thank you so much.
Sure.
At different points in the conversation so far, y'all have mentioned the joint crisis narrative. Can you unpack that for us a little bit? Tell us more about what that is and why it's important.
Yeah, I'd be happy to start that off. The joint crisis narrative is really the glue that keeps the whole intervention together. And in order to understand this, maybe I'll give you an example. So, for instance, a suicidal adolescent girl may say that she wants to kill herself because her boyfriend dumped her a week before the prom, and she's so distressed about it. Nobody will ever love her, and she certainly couldn't talk to her parents about it because they hated her boyfriend anyway. Um, and then when we actually investigate things a little bit further, we hear from the parents, "Oh my goodness, we didn't even meet her boyfriend. We didn't know anything about her boyfriend. It isn't true that we didn't like him." And that is so common for adolescents and their families coming to the emergency department, where they have very, very different narratives about what was going on, what was the trigger, and what caused the adolescent to become suicidal. In that case, it was clear what the adolescent girl felt had triggered her suicidality, and the parents had no idea. And so, what we've developed here is what we call the joint crisis narrative, which is work to bring together the two narratives, the narrative of the adolescent and the narrative of the parent, so they can listen to, hear, and understand each other's point of view and understand the barriers that got in the way of them communicating with each other. Because I don't think it'll be a surprise to anyone out there that family members are very often, if not almost always, can be the biggest support for a suicidal teenage child. And so it's really important that they be able to talk together and understand each other's point of view. I see a crisis as an opportunity. When anybody's in crisis, kind of the normally rigid ways that they might act about something become much more fluid. And if you think about it with yourself, if you've ever been in crisis, you're usually going, "Who can help me?" As opposed to, "I don't want any help." And so what happens with these families is they may have had fairly rigid boundaries around the adolescent girl talking to the family and the family asking about what was going on. But in the crisis, they are eager. They are very eager to communicate, and they are eager to find out how they can help each other. And so the work of the joint crisis narrative is where the clinician, the licensed mental health clinician, really works with each party, the adolescent and the family member, to kind of refine their narrative, but also help them to understand what was going on with the other. And so it involves some family therapy work in the emergency department. And the goal is to help each hear, understand each other's point of view, and to bring them together in a way that they can problem solve and find solutions to the problem.
That's great. Dr. Herbert or Ross, anything you'd like to add? And I know we have a lot to talk about, but that seems like such a crucial thing, and I've heard you each mention it. Building on what you were saying, Dr. Worf, about the support that family members can be when these clarifications are made, and through the tool of the joint crisis narrative, I wonder how or maybe you could tell us more about how you determine whether it's safe to send a patient back home at the end of the process, and what you're able to do to make sure they get the care they need once they're out of your emergency department.
Sure, I'd be happy to, but I think my colleagues also, I've been doing a lot of talking. Maybe I'll defer to them.
Maybe let's start with Dr. Ross and work our way what is on my screen around.
Sure. What an excellent question. And I think this kind of relates to some of the research evidence that we had talked about earlier, is that not everybody is able to go home. And I think one of the really important things about FBCI and about the way that it is operationalized and implemented is that everybody has to be on the same page about whether it is safe to go home. This means the kid, this means the family, this means the clinician, this means probably the attending psychiatrist, this means the attending physician, this means everybody needs to be on board with the fact that this is a safe option. So nobody leaves the emergency department if it is determined that it's not a safe option, if that makes sense. So I think that's part of it, and that is the biggest piece. And I think that in order to be able to deliver FBCI as a clinician, having that additional support of your colleagues around the shared decision making is a really critical component of being able to deliver FBCI and deliver it with fidelity. And that's not to say that FBCI doesn't, quote, work if patients have to stay and have to do a stint on an inpatient unit and get treatment there, because many families who did receive FBCI really benefited from the actual treatment, and I think mainly the therapeutic readiness component of FBCI, in addition to the joint crisis narrative about how to make the most of your time in the next stop of treatment along the continuum. So that's, I guess, what I would add about the how do you know when it's safe to go piece.
Dr. Herbert, is there anything you'd like to add there?
Well, absolutely. Really building off Dr. Ross, in essence, like that safe discharge for us really entailed ensuring that we would be able to connect our families. So we had a couple additional pieces that we wanted to make sure we had in terms of one, like a particular staff, which is a resource specialist, who is that person who knows so much about all of the resources available in the community. And they are the person that can really help these families get connected to the much needed services. What we try to set up here is that in working with the county, so the Orange County Healthcare Agency, of being able to get our patients and families connected to an appointment within 3 to 5 business days. Sometimes folks come during the day, and it's so much easier to get those calls into the clinic and schedule those appointments. And sometimes it might happen later after business hours. So when that happens, what we do is work with the family and empower them to call those clinics on their own, and we'll follow up, or we would schedule appointments with those families to call those clinics to set up those appointments. We really want to make sure that if they do go home, that we have that appointment scheduled for them, and then we'll follow up with them. Our counterparts in the Orange County Healthcare Agency truly were invaluable in helping us utilize those clinics particularly for the families who had Medi-Cal, so like the state insurance. And it really was invaluable, and the families really benefited from it.
Gina, just let me add a couple of short things. One is that part of the protocol for FBCI is that the clinician will reevaluate the suicidality of the teenager at the end of the intervention. So suicidality is assessed at the beginning, but also after you've gone through all of the modules, you reassess it at the end. So we know that the teenager is not suicidal. The other thing is that there is one of the modules, I think Dr. Ross mentioned it's a modular intervention. One of the modules is safety planning. And we do a structured and extensive safety plan with the adolescent and with the family before we discharge them, even before we review it with all the other professionals, as Dr. Ross meant. So we're very, very serious about making sure that the adolescent is safe to go home. And the parents have to agree that they feel comfortable taking the kid home.
That's great. Thank you all for that. We've talked about the origins and early implementation of FBCI at Boston Children's Hospital, but of course it's grown and expanded and been adapted. Dr. Herbert, can you tell us a little bit about what that growth and expansion has looked like at your facility, and then maybe the others can add?
Yeah, absolutely. gosh, this intervention is amazing, which is why I was like, I need to bring it to Children's Hospital of Orange County. And the things that we've expanded on really are just to meet the population needs. So we have a high Spanish-speaking population, and I had some really wonderful staff who speak Spanish fluently. And we had the two of the materials, it's the depression spiral and the cognitive behavioral triangle, translated into Spanish. So so they translated, my staff did, and then we also partnered with our language services department to ensure accuracy of like the translation. We are able to use that with our Spanish speaking family. So even if the child and caregiver speak English well and benefit from things like learning things in Spanish, we're able to speak in English and Spanish or utilize materials in English and Spanish. And what's really lovely is that they can take those materials home. So it's one thing when you have someone who really responds well and the primary language might be Spanish, has something in Spanish that they can read and review with their kid. When they're not just in the emergency department, they're able to use that at home. So that was one of the biggest things for us that we did. And I can definitely hand it off to Dr. Ross for any other adaptations.
Thank you, Dr. Herbert. I appreciate the attention to language and culture and all of that, because I think certainly now with the disproportionate increases in suicide, especially among ethno-racially minoritized groups, sexually minoritized groups, we really need to be thinking about adaptations for certain groups that you know, are at elevated risk. So I think other adaptations, and Dr. Herbert, you can speak to this as well. We have decided to expand FBCI across the healthcare continuum. So yes, into primary care in order to hopefully detect suicide a little bit earlier and avoid those very painful emergency department visits. And then also, Dr. Herbert and I worked together on a project to adapt FBCI for inpatient psychiatric units to hopefully reduce this kind of revolving door phenomenon that occurs where kids, once they come to the emergency department and they're admitted to an inpatient psychiatric unit, once they're 60% more likely to be readmitted. And then if they are admitted twice, it jumps to 200% more likely to be readmitted to an inpatient psychiatric unit. And if you think about kids just kind of coming in and out of the emergency department, cycling through inpatient psychiatric units, I mean, this is very disruptive and this is no way to live. So we're very excited about some of these adaptations across settings, as well as tailoring for certain populations that are at elevated risk.
That's great. Maybe connected in a way to adaptations is implementation, the question of implementation.
Yes.
Right. What is it? Maybe Dr. Ross, you can take the lead here. What helps make these implementations of FBCI so successful?
An excellent question. Many things, and I would argue, and I think the research supports this as well, both about FBCI and beyond to other evidence-based interventions. Leadership really matters. So with regard to the transportability trial that I mentioned earlier, where we had 3 sites, Boston Children's Hospital of Orange County, and UNC Chapel Hill, we selected these sites because they were in diverse areas of the country and had different arrangements with health insurance, healthcare, and a couple sites had universal and one did not. The sites were very different, not only geographically, but also in terms of population served. So one of the sites, UNC, it was actually a mixed emergency department. And by mixed, I mean a general emergency department where serves kids as well as adults, whereas Children's Hospital of Orange County and Boston Children's Hospital focus on youth. The emergency departments were also different sizes and different constellations of provider disciplines. So I think it ranged, I think as small as 6 up to 20 in terms of clinicians who were trained in FBCI. And I speak to leadership because at the time Dr. Herbert was leading the emergency service at Children's Hospital of Orange County, and some of our analysis comparing sites showed that Children's Hospital of Orange County, kids who got FBCI, kids and their families who got FBCI were 2.5 times as likely to be able to go home relative to the other 2 sites. And I think this goes to Dr. Herbert's leadership and the support that she provided to her clinicians on the ground in the moment within the emergency department, as well as that kind of outside work that she had talked about in terms of collaborating with the county and other supports outside, because FBCI is not an intervention where it's the end of the line and then everything is fine. It very much depends on that additional care and the next stop on the care continuum. And I think that Dr. Herbert and her team did very well in terms of recognizing that in the moment during the transportability trial and really securing that collaborative approach. So hats off to Dr. Herbert.
Right. Anything you'd add, Drs. Worf or Dr. Herbert?
I can just say that health insurance is also something that really influences it. You know, here in Massachusetts, we have universal health care, so we just don't see kids that don't have insurance who are citizens and have been living in this country unless they've just flown in from somewhere else. But in one of the other states, North Carolina in particular, that was not the case, and whether or not the child had health care really determined what could happen next. And in Massachusetts, we have a wonderful array of services, mental health services, outpatient mental health services for children and adolescents. We are extraordinarily fortunate, but other states do not. So that's another thing that is really important, because as Dr. Ross said, FBCI is not the end of the line. There needs to be a next step. We get them kind of spruced up, and then they need to get treatment. And if they can't find it, then that's a big problem.
If there are emergency mental health providers or institutions who'd like to learn more about using FBCI or how to access it, what should they do?
Well, definitely they should contact Dr. Ross or me. And I suspect you probably can provide them with our email addresses. I don't remember if we had those, but it would be fine for them to email us. We have developed an online training portal for FBCI in the emergency department through Open Pediatrics at Children's Hospital. And so we would be happy to talk with people and develop a contract with them for using our training materials. And we're just happy to talk with them more. We, as you can tell, talk. We love to talk about FBCI.
Dr. Herbert is a featured clinician in our updated training, so even more of a reason to be in touch.
There we go. Well, we're coming to the end of our time, but is there anything we might have missed a chance to talk about that any of the three of you would like to share or make sure people understand?
I will just say one more thing, and that is that, well, first of all, I want to thank my colleagues and thank the Harvard School of Public Health for having us. It's been wonderful. And I think the more the message gets out, the better. But I know that Dr. Herbert mentioned a suicide screening measure, the ASQ, Ask Suicide Screening Questions, that is out in the public domain. I'm one of the developers, so I want to publicize it. It's excellent, easy 4-item suicide screening measure that you can find. It's on the website at NIH. And if you just Google Ask Suicide Screening Measures or ASQ Suicide Screening, something like that, you can find it. It's in the public domain, and it's for everybody from the ages of 8 up to 25. And it's very easy. And the reason I bring it up is that we would much rather not have the suicidal teenagers coming to the emergency department at all. We would rather that somebody, a pediatrician or a psychotherapist, screened them for suicide and really helped them along the way when they were maybe just beginning to feel bad. So although our intervention is, I think, fantastic for the emergency department, the very best thing would be to reduce the number of suicidal adolescents overall.
Great.
We just can support.
Share. Oh, sorry. We'll find and share the link to that public domain screener on the page for this as well. So Great. If folks want to go to that page to find it, they'll be able to do that.
I
Sorry,
just
Dr.
wanted
Ross.
to add a point, yes, to support what Dr. Worf is saying about the ASQ or the ask. I think there is still a pretty pervasive myth out there that asking about suicide is going to put the idea in somebody's head. There is research that has shown that that is actually not accurate. So I just wanted to take the opportunity to disabuse everyone of the notion that asking is going to cause or contribute to suicidality. Much better to ask than to not.
Thank you. Thank you for that. Well, thank you all also for being here today, for sharing this really interesting and crucial information, for the thoughtful discussion we've had about a really important topic. We're grateful to have you with us. We're grateful to have learned from you. For those who want to watch all of the videos in this series from our Public Health in Action program here at Harvard Public Health, you can visit the magazine's website, harvardpublichealth.org/action. Thank you again.